A real clinical case: a teenager with autism develops a rash and joint pain. A large language model is asked for the diagnosis. It suggests immune thrombocytopenic purpura. But the physician diagnosis was something much older: scurvy. Yes, vitamin C deficiency. The AI missed the clinical clue that changed the whole case: context. And that is the real problem with medical AI. It knows a lot, but it does not know what matters. Welcome to Clinical AI Academy Rounds, where we discuss the intersection of artificial intelligence and healthcare, with the goal of improving AI literacy among clinicians. In 2024 study in JAMA Pediatrics, researchers tested ChatGPT on 100 pediatric diagnostic case challenges, featuring real clinical cases from JAMA Pediatrics and the New England Journal of Medicine. The prompt was simple: list a differential diagnosis and a final diagnosis. The model had an overall diagnostic error rate of 83%, meaning only 17% of overall diagnostic accuracy. 72 cases were incorrect. 11 more were clinically related, but too broad to count as correct. And in only 36 of the 100 cases did the correct diagnosis appear somewhere in the AI-generated differential list. One representative case was exactly the one we opened with: rash and arthralgias in a teenager with autism. The model suggested immune thrombocytopenic purpura. The physician diagnosis was scurvy. The model recognized a symptom pattern, but the correct diagnosis depended on a relationship between neurodevelopmental context, possible restricted diet, vitamin deficiency, and physical findings. The authors specifically noted that the model did not identify relationships such as the one between autism and vitamin deficiencies. That is the kind of clue that goes beyond the first symptom list. But here is where we need to be careful. The lesson is not simply AI is bad at rare diseases. That would be too easy and not fully true. Some studies suggest that large language models may actually help with rare disease diagnosis when they are given rich clinical summaries. For example, a 2025 JAMA network open study tested large language models on 90 solved cases from the Undiagnosed Diseases Network. ChatGPT 4.0 identified the exact final diagnosis in 13.3% of cases and produced a helpful differential in 23.3% of cases. That may sound modest, but the historical clinical review rate used for comparison was 5.6%, and the model generated differentials quickly and cheaply. Another 2025 study in Orphanet Journal of Rare Diseases evaluated 4 large language models on 152 rare disease cases. In that study, Claude 3.5 Sonnet reached 78.9% accuracy, ChatGPT 4.0 reached 63.2%, and the human physician comparator reached 26.3%. But the authors also emphasized important limitations: retrospective cases, geographic bias, simplified output, and a very limited physician comparator. So the honest conclusion is more interesting. AI may be useful for generating rare disease hypotheses, but it is much weaker when the real clinical problem is messy, incomplete, early, or badly framed. In real medicine, the hard part is deciding which clues to look for. The National Academies describe the diagnostic process as a complex, patient-centered, collaborative activity involving information gathering and clinical reasoning over time. A chatbot does not naturally perform that process. It receives a prompt. Then it predicts a response. And if the prompt is incomplete, the response may be beautifully written and clinically wrong. This creates 4 common failure modes. First, missing context. If the prompt says rash and joint pain, scurvy may not rise to the top. If the prompt adds restricted diet, neurodevelopmental condition, gum changes, bruising, and poor intake, the diagnosis becomes much more visible. Second, premature closure. The model may quickly converge on a coherent diagnosis instead of protecting uncertainty. That matters because good clinicians do not only ask, "What is the most likely diagnosis?" They also ask, "What must I not miss?" Third, wrong task framing. Patients often ask, "Is this serious?" or "Could this be from my medication?" or "Can I wait?" But the safer clinical question may be, "What dangerous diagnosis must be ruled out today?" Fourth, final answer bias. Many benchmarks reward the model for producing the correct final diagnosis. But bedside medicine rewards something different: the ability to build, revise, and test a differential diagnosis. A 2026 JAMA Network Open study tested 21 large language models across clinical reasoning tasks. The models performed much better on final diagnosis than on differential diagnosis. Failure rates for differential diagnosis exceeded 80% across models, while failure rates for final diagnosis were below 40%. The authors warned that models tend to collapse prematurely onto single answers, especially where uncertainty matters most. That is the key distinction. AI often looks strongest after the case has already been cleaned up. Clinicians are needed before that, when the case is still unclear. So how should clinicians use diagnostic AI safely, not as an answer machine? Use it as a differential diagnosis stress test. Here is a safer prompt structure. Given this presentation, generate a broad differential diagnosis. Separate common causes, dangerous diagnoses, and rare but plausible diagnoses. For each, list the missing history, examination findings, basic tests, and red flags that would increase or decrease probability. Do not give a final diagnosis until the missing information is addressed. That prompt changes the task. Instead of asking the model to be a doctor, you are asking it to challenge your frame. I would use 5 questions whenever AI suggests a diagnosis. 1. What important diagnoses are missing from this differential? 2. What dangerous diagnosis would be harmed by delay? 3. What single piece of history would most change the ranking? 4. What finding would make this diagnosis unlikely? 5. What patient-specific context might the prompt have omitted? In the scurvy example, that missing context may be diet. In another case, it may be a medication, or travel, or occupational exposure, or pregnancy, or immune suppression, or the fact that the patient is not describing the symptom in medically precise language. The AI can only reason from the story it receives. The clinician's job is to rebuild the story. So did ChatGPT miss scurvy because it had never heard of scurvy? Probably not. It missed scurvy because diagnosis is not just a knowledge test. Diagnosis is a process of asking better questions, preserving uncertainty, and knowing which details change the case. What diagnosis do you think AI is most likely to miss? The rare one, the urgent one, or the one hidden in the history? Let me know in the comments. See you in the next round.